Okay, good morning, students. Can you all hear me?
Yes, doctor.
Yeah. Can you all see this slide here?
Yes, doctor.
Okay, okay. The recording has started, right?
Yes, doctor.
Okay, thank you. Okay. So today's topic of the lecture is neuromuscular blocking agents and directly acting muscle relaxants. Okay. So most of the topics, if you see in pharmacology, when you look at the topic, you exactly know what we are discussing about. Now, looking at this topic, what do you think we are going to discuss about in this 1 hour lecture? What do you think we are going to discuss or talk about?
My guess would be different types of muscle relaxants and their clinical application and effects.
Yeah, we are going to talk about different muscle relaxants and their application. Where do you think these muscle relaxants are used? Where do you think these muscle relaxants are used?
Surgery.
Okay, before a surgery, very good. Only surgery, any other way, any other place you can use this?
Sedation, maybe.
For sedation, you use muscle relaxants?
For someone who's undergoing anaphylactic shock.
Sorry?
For someone who's undergoing anaphylactic shock.
Do you give a muscle relaxant when you are in anaphylactic shock? No, we don't. Okay, never mind. Some of you know
Is
it.
it used in the
Sorry?
is it used for I'm not sure about this, but in countries that instate the death sentence by injection?
In countries, they use euthanasia, is it?
No, I said in countries that use that still allow the death sentence by injection.
Okay, muscle relaxants also are used, but this is not exactly a major use of the drug. The
Muscle cramp.
yes, in muscle spasm. If you like, for example, you went for a game of football and you had a very bad muscle catch or a muscle spasm. In that case, also you can give this muscle relaxant. So you can give it to very major conditions like before a surgery to a very minor condition where you have a bad muscle catch after a play, like you go for a football or a badminton, whatever. Okay. Now, these are the learning outcomes. I'm sure I don't have to read the learning outcomes. You know the learning out. You can always read this. So this is the learning outcome at the end of the lecture. Now let's see. Now, if you see this this whole picture here, what you have, if I may have to explain this picture, this is a surgical table where this is the operation theater, and the surgeons are doing something. So in this, of course, surgeons will perform a surgery on the patient. So in this scenario, in this case, what do you think are the drugs which is very useful for a surgeon? That is to perform this procedure. What drugs do you think are useful? It's okay. I mean, just have a wild guess or just think out of the box and tell me.
Sedative drugs.
Yes, you need sedative drugs. Okay, then.
Anesthetics.
Anesthetics, you need anesthetics. Of course, before a surgery, the patient should go for, you should anesthetize the patient, right? Either you generally give a general anesthetic or a local anesthetic. Very good. Anything else?
Atropine.
Atropine you give, okay, to reduce the secretion. Good, okay. Anything else you want to give? Good, good. Yeah, the answers are coming.
Miss, I'm not sure if this is correct. I've heard about ketamine.
Yeah, that's an anesthesia. That's an anesthetic. Okay. You said you need anesthetics, you need sedation, GERD. Then some of you said something else. You said, oh, ketamine, that's an anesthetic. So anything else you need other than these drugs?
Blood thinners.
Sorry?
Blood thinners.
Sorry?
Blood thinner.
Blood thinner, do you want to give in a patient who's undergoing a surgery where clotting is reduced? That means it can increase the surgery risk of bleeding, right? So you don't want to give a blood thinner. Suppose you want a very easy for the surgeon to operate on. What drug will help the surgeon to operate very easily?
Muscle
relaxant.
relaxant.
Sorry,
Muscle relaxant.
louder, please.
Muscle relaxant.
Yes, muscle relaxants. You want to give muscle relaxant so that you relax the muscle, so that when the surgeon puts the incision, and of course he has to separate the muscles, right, of the, if he's doing an abdominal surgery or a limb surgery, whatever it is, he has to relax the muscles, right? For relaxation of the muscle, you need a muscle relaxant. So muscle relaxant, the is one of the part of the surgery. So what we are going to talk about is what are the different muscle relaxants you can give for a patient, what is the mechanism, and what are the adverse effect, and where do you use it. Now, to recap or things what you've already learned in your autonomic nervous system, you have the muscarinic receptors and the nicotinic receptors. You have 5 muscarinic and 2 nicotinic receptors. Nicotinic can be present at the NM junction, as that is in the neuromuscular junction, and also neuronal nicotinic receptors in the ganglia. Okay, so these are the two. Basically, now we are going to talk about the nicotinic receptors because our drugs will act on that mainly. Of course, we are talking about certain drugs which act on the acetylcholine also. Now, this is just a recap again. Acetyl-CoA plus choline forms acetylcholine by the enzyme cholinestyl transferase, and this acetylcholine is degraded to acetate and choline by the enzyme acetylcholinesterase, which is called as 2-cholinesterase. And there are drugs which inhibits this acetylcholinesterase enzyme. Can you name some drug which inhibits this acetylcholinesterase? Any idea? And so that inhibits the breakdown of acetylcholine.
Neostigmine.
Neostigmine, very good. Neostigmine, physostigmine, all these drugs they belong to this class. Okay, so now this is the neuromuscular junction where you have the vesicles with the acetylcholine, and down we have the receptors. So once the acetylcholine is released, either they can act on these acetylcholine receptors, or they can be degraded by these enzymes acetylcholinesterase, or some of them can go back to the nerve terminal also. Okay, so these are the different ways it can act. So now this is just a recap of whatever you've already learned, just to know that just to remind you that you know all this, because when I'm talking about the mechanism, these are the things which you should know, and I presume that you already know about it. Okay, so skeletal muscle relaxants can be of two types: neuromuscular blockers, and another type is spasmolytics. Under neuromuscular blockers, which is peripherally acting, you have the non-depolarizing neuromuscular blocker. Example is D-tuberculin. Now, I want to tell you one thing. When we talk about examples of drugs, when you go back to your textbooks, many students have this doubt, like in our textbook, there are so many examples about drugs which are given to us. Do we have to remember everything? Okay, as undergraduate student, you don't need to remember everything. Okay, but what we put in the slide is the minimum you need to remember. I'm not telling you remember only this. This is the minimum. This you have to remember at any cost. But the other drugs which are there in the textbook, for each class, if you remember 2 examples, good enough. Okay, because you are doing medical sciences. When you go to clinical sciences, you need to remember more drugs. So for medical sciences, you at least need to remember 2 examples of a certain class. Now, I have mainly you have to remember this prototype drugs which I have mentioned here. This is a must. You have to remember, like if I say non-depolarizing blocker example, if I say D2-becquerel, you should know that it is a non-depolarizing blocker. If I say succinylcholine, you should know it is a depolarizing blocker. So non-depolarizing blocker, they are D2-becquerel. Depolarizing example is succinylcholine or succinylmethonium. Spasmolytics they can be centrally acting, like diazepam. This diazepam you will learn in your semester 4, I think. In diazepam is centrally is a muscle relaxant. Then you have baclofen and tizanidine. Again, I've given you just a few examples. I've not given you the whole list. Directly acting on the muscle, that is dantrolene. Okay, so you have two types, neuromuscular blockers and spasmolytics. So this is the classification with example. Now let's talk about first about the neuromuscular blocking agents. Now first let's talk about a little bit about succinylcholine. Now succinylcholine, basically it resembles acetylcholine. Basically it is two molecules of acetylcholine. Okay, because it contains, in this chemical structure, it has one or two quaternary nitrogen. It is poorly lipid soluble and limited, because you have already learnt about volume of distribution in your general pharmacology. You know, a drug which is less lipid soluble, that means its volume of distribution is less, because it cannot go to the other tissue because of its less lipid solubility. And because of its less lipid solubility, difficulty moving across membrane is very difficult, and so its entry is limited to the central nervous system. So it is peripheral acting. Okay, so neuromuscular blockers basically are peripherally acting. First, let's talk about non-depolarizing muscle relaxants. Okay, so now many centuries back, what they used to do in the South American natives, they derived a plant derived arrow poison. Okay, this is got from a plant, and they made a arrow poison. They took this and made an arrow, and what they did was they used to kill the animals. Like for example, in the olden, or not olden days, in like centuries ago, they didn't have this food which they just ate the animals which they found in the forest. They ate the fruits which they found in the trees. Just they didn't cook the food or whatever animals they found, they killed the animals and they ate. The native South American natives did the same. They made a plant derived arrow, which is actually curare was a poison. So what they did, they made an arrow and they used it to kill the animals. No, now the killed animals can be eaten without risk. You might wonder, like, okay, fine, these animals are killed because of the poison, and the poison enters the animals, and if they eat it, how will it be? Why will they want it poison the person who's eating as well? Because in olden days they never used to cook the food properly. So, but the reason for it is the absorption of the poison from the GIT was virtually nil. So if they ate it orally, the absorption of the poison was not there. So they did not, the people who ate the meat or the flesh from that animal did not develop any symptoms of poisoning, but it was poisonous for the animal which the arrow was used to kill them. Okay, this is a little bit of a trivia on the history of non-depolarizing muscle relaxant, because this is where they first came into use. Let's come to the mechanism of action. Now, you all have already learned about nicotinic, the competitive antagonism and non-competitive antagonism. In competitive antagonism, what exactly happens? Can somebody tell me what happens in competitive antagonism?
So basically, two compounds compete for the same binding site on a receptor.
Okay, they compete for the same binding site. Now, that means the antagonist will block the receptor, right? Now, if the receptor blocking happens, can your receptor, this blocking action be reversed?
Yes.
Yes, this blocking action can be reversed. How do you reverse this blocking action?
By increasing the concentration of acetylcholine.
Yes, by increasing the concentration of the agonist. Okay. Okay, so you know the underlying concept. So let's go to the mechanism. Okay, now D-tuberculin is what is the non-depolarizing blocker here. So what happens is they act on the nicotinic receptor at the neuromuscular junction. Due to, at the NM junction, it is acetylcholine, which is the neurotransmitter, which goes and binds to it. Now, you give D-tuberculin, it displaces this acetylcholine and goes and binds. So it blocks the acetylcholine receptor at the neuromuscular junction. So when it blocks the acetylcholine receptors, there is relaxation of the muscles. Okay, this is muscle relaxation. So this whole phenomena, competitive antagonism occurs. They prevent the binding of acetylcholine to this NM receptor, and if you have to reverse this block, then you have to give a drug which reverses this block. I'll talk about it in the next few slides. Okay, so the paralysis, when you give a D-tuberculin, that is a non-depolarizing blocker, the paralysis occurs in a sequential manner. First the face, limbs, and then last the respiratory muscles. Now, when you give a muscle relaxant, you don't want the respiratory muscles to get paralyzed, because of course if your respiratory muscle paralyzed, the patient may die. So respiratory muscle paralyzed means you have not given, either you have not uh, um, uh, given the drug in the correct dose, or you have given a very high dose of the drug, which has led to toxicity. Because when you give a drug for muscle paralysis, it should not go to a state of respiratory paralysis where you can kill the patient. Okay, so this is it happens in a progressive manner. And if you know, these are skeletal muscle relaxants, so they do not have effects on the cardiac and smooth muscles. Okay, so they do not have effect on cardiac and smooth muscle, and no CNS effects also, because they are peripherally acting. So basically what if you see this picture here, this is the nicotinic receptor, the gate of the nicotinic receptor. They have a closed normally. When you give a non-depolarizing blocker, if you see, the gate of the receptor is here is closed. Okay, the gate is closed, and now once that is closed, now when you give a non-depolarizing blocker, the gate is closed and it blocks. It does not allow the receptor to open the channel gate. Okay, so the nicotinic receptor, the channel gate does not open. Okay, so in case so non-depolarizing blocks, it's called as closed block. That means it closed and it is blocked. So non-depolarizing blocker, this is how it looks. So what are the common adverse effects you see? So in case of, if you give a non-depolarizing blocker, the patient can go into hypoxia and respiratory paralysis. But remember, as I told you, this adverse effects is seen when you give a very high dose of the drug, or maybe you have not reversed the block when it is required. Then it also causes hypotension and bronchospasm. The reason for this hypotension and bronchospasm is, when you give a non-depolarizing blocker, what they do is they release histamine. Okay, in allergic conditions, some drugs can, so they release histamine, and because they release histamine, they cause hypotension and bronchospasm. Okay, now you already explained to me about the competitive antagonism and all that. So in case of competitive antagonism, if you want to reverse the block, what you need to do, you need to increase the concentration of the agonist. So how do you do that? How do you reverse the block? Now suppose you give a D-tuberculin for a patient, like for example, you want to cause relaxation of the muscle for a surgery. Now you finish the surgery, and after the surgery you want to reverse the block. So if you want to reverse the block, what do you think you want to do for this patient to reverse the block? Any idea? You have learned your autonomic nervous system. Any idea how you want to reverse the block? It's okay if your answer is wrong, no problem. How do you want to reverse the block? Yeah, Yeah, go ahead.
By increasing
How do you want to reverse the, sorry?
By increasing the acetylcholine levels?
Yes, very good. You're going to increase the concentration of acetylcholine. That is the agonist. Now, how do you want to increase? What drug can you give to increase the acetylcholine?
An anticholinesterase?
Yes, anticholinesterase. Very good. Like neostigmine. Neostigmine is peripherally, it acts peripherally. So you can reverse the block by giving a non-dipolar, by giving a anticholinesterase drug, by giving neostigmine. Now, what is this neostigmine? As we already discussed, it is a drug which blocks the enzyme anticholinesterase, and because of this, the breakdown of acetylcholine does not happen. So the acetylcholine level is increased. So what are you doing? You're increasing the concentration of the agonist, that is the acetylcholine concentration. So this is how you are going to reverse the block. So what is it called? As you already know, it is called as competitive antagonism. You have already learnt in your general pharmacology. Let's go to a quick knowledge check in between which drug is most often associated with hypertension caused by histamine release. Which drug is that?
Is it tubercularine?
Yes, it is tubercularine. That is the drug which causes hypertension because of histamine release. You know, histamine causes hypertension, and because of that, histamine causes hypertension and also causes bronchospasm. Okay, so this is the right answer. Are you clear about non-depolarizing blockers? Yeah?
Yes, doctor.
To depolarizing blocker, the prototype example is succinylcholine, and some books gives it as succinylmethonium. It's also okay. So actually, basically, this depolarizing blocker succinylcholine is basically two molecules of acetylcholine linked with the acetylmethyl group. Now, and they are now. If you see here, I told you this is sorry. It blocks the nicotinic receptors at the NM junction. It is a nicotinic receptor blocker. Okay. Now, if you see depolarizing blockers, they are agonist at the nicotinic receptor. Now, you might wonder, like one is an antagonist, one is an agonist, but both of them bring skeletal muscle relaxation and helps in surgery. So they act on the same receptor, but their action is different. Mechanism by which they bring about its relaxation is different. Now, you might ask me this question, okay, this chemical structure is there. Do I have to remember this chemical structure? No, you do not have to remember. Just remember that succinylcholine is basically two molecules of acetylcholine. You don't have to remember, and some people are very good in chemistry. If you want to remember, you can remember by all means for your extra knowledge. No problem at all, okay? Now let's go to the mechanism of depolarizing blocker. If you remember the previous picture which I showed you about a non-depolarizing blocker, you had the same channel here, the channel gate here, where the agonist will bind. This is the open normal. Okay, this is open. Okay, but open closed. Okay, when it is open closed, what happens in the depolarizing blocker? It's blocked here and it is blocked here, two sides. Now that was closed. The channel itself was closed, but here it is open, but here it is blocked. The depolarizing blocker blocks at this side, so the ion channel cannot open or close. In the receptor, the channel gate cannot open or close because it is open. Because the binding is here, it does not, it cannot close. Okay, that was closed, totally closed, and the receptor, the depolarizing, the agonist or whatever, the drug was bound here and it is totally closed. But in this bound here and also here, you cannot open or you can't close it because the drug is bound in the inner part of the channel gate. Okay, so what exactly happens here is Succinylcholine, what does it do? It goes and binds to the NM receptors. That is the nicotinic receptors in the neuromuscular junction. So once it binds to the NM receptors, what happens is it opens the sodium channels and causes depolarization. Now I have to tell you this before I move forward. You have to know your physiology very well before you understand the mechanism of the depolarizing and non-depolarizing blocker, especially depolarizing blocker. So when you're reading this, please go to your physiology textbooks. Please learn what is action potential. Please learn what is depolarization. Please learn what is repolarization. Then start reading this. Otherwise, you will have a lot of questions. Understand the concept there and then read this, you will understand better. So unless you don't have your physiology knowledge, it is very, very difficult for you to understand this. So please learn your physiology well before you understand this. Okay. So what does it do is succinylcholine binds to the NM receptors. It opens the sodium channels and causes depolarization. Okay. So when it causes depolarization, this depolarization spreads all over and result in because of this repolarization and because of the spread of this depolarization, it causes repetitive excitation of the muscle motor units. Okay, so repetitive excitation and causes transient because of this spread of the depolarization. There is repetitive excitation of the muscle. When the muscles are excited, they cause something called as muscle fasciculations. It is transient. Transient means it's for a short duration of time. Fasciculation means something like twitching. You get small muscle contractions everywhere. Sometimes you might have realized, sometimes you have some small muscle contraction in the eyes and all that, no? So that is called as fasciculation, small muscle contraction. And what happens is, succinylcholine is 2 molecules of acetylcholine, and you remember succinylcholine, it cannot be metabolized by acetylcholinesterase. It does not get metabolized, and because it is not metabolized, succinylcholine is already 2 molecules of acetylcholine, right? So there is more acetylcholine. So acetylcholine, this succinylcholine, more of succinylcholine leads to persistent depolarization of the muscle fibers. See, because of this succinylcholine, there is already depolarization occurring. Now, succinylcholine is not metabolizing. So, because of that, there is persistent depolarization of the muscle fibers. More depolarization because of persistent depolarization. Because of persistent, persistent twitching, muscle fasciculation, there is and then there is persistent depolarization of the muscle fibers. And because of this persistent depolarization, the patient muscle fasciculates. This results in muscle fasciculation, more fasciculation, and ultimately leads to paralysis. So if this picture will give you a better idea, where if you see here, there are 2 phases in the mechanism of depolarizing blocker. First is the depolarizing phase and next is the desensitizing phase. Okay, basically all the muscle relaxation which happens is in the phase 1. Okay, so what happens, there is when you give succinylcholine, there is brief. Now if you see it on the left hand side here, normally what happens is propagation of action potential, and this acetylcholine is broken down by acetylcholinesterase. Then there is repolarization of the end plate and new action potential is generated. But when you give succinylcholine, what happens is succinylcholine muscle contraction occurs. It is not broken down by acetylcholinesterase. Remember, so depolarization, there is persistent depolarization occurring without repolarization, and so because of that, new action potential and contraction cannot be elicited. It's still in the repolarization state, and which leads to prolonged muscle relaxation. So if you see here in phase 1 block, following depolarization, there is fasciculation, that is twitching, and then there is a facet paralysis which develops when if you give so in this case, if you see a non-depolarizing blocker, what happened, you gave an acetylcholinesterase and the block could be reversed because there is competitive antagonism. But here, if you're giving acetylcholinesterase inhibitors, you're giving more of acetylcholine. Succinylcholine is already acetylcholine. So you cannot reverse the block. You're actually making the block more deeper. So you cannot give a anticholinesterase to reverse the block. So if you continue giving succinylcholine for a long time, what happens is it keeps stimulating the receptor more and more and more. And because of that, the receptor gets desensitized. That means sensation of the receptor comes down and it becomes unresponsive to acetylcholine for some time before requiring. After some time, it stopped responding to acetylcholine at all. Okay, so there comes a desensitizing phase. So these are the two different phases. But basically, when we talk about muscle relaxation, we talk about it in phase 1. Phase 2 happens if you give a very high dose of succinylcholine, or you give succinylcholine for a longer duration of time. Okay, so this is the mechanism. So any doubts in this? Any doubts in the mechanism of action of depolarizing blockers?
Ma'am, I just had a question.
Yes.
So the phase 2 block or desensitizing, can we say that a down regulation is happening or no?
Okay, we can say, you're saying the number of receptors comes down. Okay, maybe that could be one of the reasons for desensitization. Yes, yes. This basically, the sensitivity of the receptor comes down more than total down regulation. Down regulation can also be the reason for desensitization.
Okay, ma'am. Thank you.
Yeah. Any other? Somebody else was about to ask me some question. Okay, we'll go forward. Maybe at the end of the class, you will have more question. Okay, so now succinylcholine, what happens is, basically it does not get broken down by acetylcholinesterase. In fact, it gets broken down by a enzyme in the plasma called as pseudocholinesterase in the plasma. So what happened when you give succinylcholine? It is very short acting. This enzyme in the plasma will break it down to succinyl monocholine by the enzyme pseudocholinesterase, and that to succinic acid was proline. So rapid hydrolysis of the drug occurs in the plasma. So basically it acts, onset of action is within few seconds. It's very quick acting. So in case of surgery where you need muscle relaxation, or you need a procedure where muscle relaxation has to be quick, you can give it. Okay, it's a rapid onset of action, 60 to 90 seconds, and duration of action is 5 to 10 minutes. So duration of action of the drug is 5 to 10 minutes. It lasts for 5 to 10 minutes. Okay, what are the adverse effects of the depolarizing neuromuscular blocker? Okay, they can cause hyperkalemia. So hyperkalemia can be one of the adverse effects. It can cause an adverse effect called as malignant hypothermia. I'll tell you what malignant hypothermia is. Now, remember, this malignant hypothermia will not be seen in all the individuals. It is seen in only genetically predisposed individual. Okay, genetically, some individuals will have some genetic mutation in a receptor called as ryanodine receptor. Okay, so genetically what happens when they have this mutation in the ryanodine receptors, what happens is there is persistent release of calcium from the sarcoplasmic reticulum via the RAR1 channel. Okay, because of this mutation, there is high release of calcium from the sarcoplasmic reticulum. Okay, because of this increased release of calcium, what happens is, calcium causes muscle contraction. You might have learned in your physiology, you need calcium for muscle contraction. Because of increased calcium, there is persistent contraction of the muscle, and that contraction of the muscle, when muscle contracts, it leads to heat production, and because of this heat production, there is increase in body temperature, and also can lead to lactic acidosis. Increased body temperature and can cause lactic acidosis. So remember, this is only seen in genetically predisposed individual. If you give a depolarizing blocker, not in all the individuals. Okay. Also, there's another defect which you see in case of genetically predisposed individuals, where you see if there is some mutation in the sodium's channel. Okay, there's a mutation in the sodium channel. So because of that, they call in such individual, when you give a depolarizing blocker, they can cause rigidity of the masseter muscle. Masseter is the muscle of the jaw. Okay, so masseter muscle, there is a rigidity of the masseter muscle. So if you want to intubate the patient might the patient might not be able to open his mouth, okay, because of the rigidity of the muscle, soreness of the muscle. Now in depolarizing blocker, I said the patient will have fasciculation first before the paralysis, right? This fasciculation which develops can lead to soreness of the muscle. And one more most important, this is very important for you to know, they cause an adverse effect called as succinylcholine apnea. This also is seen only in genetically predisposed individuals, where some group of individuals from certain race or certain community have a genetic abnormality, where they have a defective pseudocholinesterase in the plasma, or there is no pseudocholinesterase in the plasma. So because of this, I told you in my previous slide that succinylcholine breaks down so succinylcholine is broken down by pseudocholinesterase present in plasma, right? So if these individuals are exposed to these depolarizing blockers, this breakdown of succinylcholine does not take place. So the succinylcholine will be in the body for a long time, and because of the prolonged muscle relaxation, they can cause a condition called as succinylcholine apnea. Apnea means difficulty in breathing. Okay, they have apnea means they are not able to breathe. Okay, so because in a genetically predisposed person, pseudocholinesterase will not break down the succinylcholine, and because of that, succinylcholine will be present for a longer time, and then can lead to succinylcholine apnea. So remember, malignant hypothermia, masseter muscle rigidity, succinylcholine apnea, all this seen in genetically predisposed individuals. Okay, because of all this abnormality in their maybe in the channels or the enzymes or whatever. Okay, succinylcholine has some significant side effects, one of which limits its use in patients suffering from major burns. This side effect is what? What is this side effect? It's hyperkalemia. In patients with burn, what happens is, already because of there is outward efflux of the potassium uh, in case of burn, in a patient with burn, right? There is already a hyperkalemia which is seen. Okay, so when the succinylcholine also causes hyperkalemia, and if in a burns patient you give succinylcholine, the hyperkalemia can be worsened. It can worsen in case of patients with burn. So it is, hyperkalemia is the adverse effect. Okay, till now are you all clear, students? Any doubt till now? Okay, let's go to the next. Of course, at the end of the class, you can still ask me doubts. Okay. Okay, now let's go to the difference between a depolarizing and a non-depolarizing blocker. This is the same what you just learned till now. Let's just go and check what is the difference. So as you know, non-depolarizing blocker with neostigmine, it can have a antagonistic action. That means it can reverse its block. But if you give neostigmine for a depolarizing blocker, it can have an additive effect. It can worsen the block. With general anesthetic, it can, non-depolarizing blocker can, synergistic means it can have a more effect if you give a general anesthetic, because some general anesthetic also act in the same way as this non-depolarizing blocker. They can have muscle relaxant action also. So they can have potentiate the effect, but in case of depolarizing blocker, no, it does not have, because the effect is in a different way. So, but in patient with genetic predisposition, they can cause malignant hypothermia with because some general anesthetics also cause malignant hypothermia, and if you give a depolarizing blocker, that together can cause malignant hypothermia. Aminoglycosides, it's an antibiotic which also it also has a non-depolarizing neuromuscular blockade type of an effect. So it can potentiate the effect of this, but the depolarizing blocker does not have any effect. So the uses of skeletal muscle relaxants. So in the starting of the class, you already told, some of you have already told me the uses. I just list it out again. Intraoperative use as an adjuvant. Adjuvant means along with, okay, along with general anesthesia. You want to paralyze the muscle for the surgery, for a good operative field for the surgeon. For intubation, okay, for intubation you can use this. In case of orthopedic surgeons, if they want to reduce the fracture or some orthopedic manipulation, you have to give a skeletal muscle relaxant so that it becomes easier for the surgeons to manipulate to prevent trauma. Electroconvulsive therapy, you might have heard about. In patient with depression, they give shock treatment and all that. That is called as electroconvulsive therapy. So in case of that, you need a little bit of a muscle relaxation, you give this. Use on mechanical ventilation. If you want to put a patient on mechanical ventilation, you need to intubate the patient. You have to muscle relaxation should be obtained by giving a muscle relaxant in patients in ICU on control or assisted ventilation. In that case, if the patient to get intubated, you have to give a muscle relaxation for this patient. So these are some of the of skeletal muscle relaxants. Now this is something called as endotracheal intubation. This procedure is so this is endotracheal intubation. Which is the neuromuscular blocker of choice in this patient? Which do you think? This is an emergency condition where you want to intubate the patient. Maybe he's going to respiratory failure or whatever. So what neuromuscular blocker you want to give in this patient? Which do you think? You want to give a depolarizing or a non-depolarizing?
Succinylcholine.
Succinylcholine. Good. You want to give succinylcholine. Why do you want to give succinylcholine?
It can
Sorry?
have effect very fast.
Very good. Because it is a fast acting. Because it is fast acting. So you want to give it, and it has a short duration. So it is an emergency, right? You want to have an effect fast, and of course, because this intubation is a very short procedure. You just put the intubate the patient. It takes a few seconds or a minute or so. So short duration. Okay. So recap on the mechanism of action of both the blockers, site of action, NM receptor at the neuromuscular junction, D2-baccarin, succinylcholine at the, again both are in the same place, but the action is different. One will block the receptor, other will occupy, just like acetylcholine. That means it has an agonistic effect. Effect on the muscle cell membrane, no depolarization takes place, but here you have depolarization, prolonged depolarization, and then it goes to phase 2, phase 1 and phase 2. Effect on the muscle, there is facet paralysis directly, but here if you see, there is initial fasciculation and then facet paralysis. So effect of neostigmine, they have when you give neostigmine, it has an antagonist action. That means it reverses the effect of tibacarin. But acetylcholine, it additive effect. You give, and from phase, if you give more of neostigmine from phase 1, it can go to phase 2 also. You cannot, it has a additive effect. So difference in the pharmacokinetic features, orally D2-baccarin or succinyl cannot be given. They given as intravenous. The volume of distribution is very low because of less lipid solubility. Penetration of the blood-brain barrier and placenta is less, again because of less lipid solubility. So they are peripherally acting. This is D-baccarin is not metabolized, but this is metabolized by plasma, decholinesterase. This is very important. That's why we talk about the succinylcholine apnea. Now this, if you see T tuberculosis, you can give it for a long surgery because its duration is for 80 to 120 minutes, and this is quick, just for 5 to 8 minutes. So it's so quick acting succinylcholine. So coming to a quick knowledge check, a 45-year-old patient is involved in a car accident. Is brought to the emergency. Shortly before endotracheal tube is inserted, the mechanical ventilation is initiated and rapidly acting depolarizing neuromuscular blocker is administered. Which is the likely drug used for the muscle relaxation? Which is it? Which is it?
Is it D?
Yes, it is succinylcholine. Rapid action, endotracheal intubation, depolarizing blocker. Everything is a clue for your question. Next, coming to the spasmolytics. Now, spasmolytics, as I told you, they are centrally acting and they reduce the skeletal muscle tone without altering the consciousness. They do not have any effect on the consciousness. Maximum they can cause sedation, but not real alteration in the consciousness. You can use this in cases of any spasticity, when your muscle is spastic, spasm of any of the muscles, like for example multiple sclerosis, which there is it's a autoimmune disorder where all the muscles are spastic muscles. Cerebral palsy is a disorder where the muscles are there is no relaxation of the muscle. So if you want to relax the muscle in such cases, for symptomatic relief you can give. Of course, they do not give total relief, but symptomatic. Acute muscle spasm from any strain, like for example, as I told you, you went for a game to play out, or maybe you lifted a heavy weight. In such cases, you can give this spasmolytic agents. So it's very less effective in improving the functional status. Example, mobility, like for example, like in cerebral palsy, it can release the spasm, but you can't expect the patient to walk normally with this spasmolytic. So functional status cannot be altered, but they can, little bit relaxation can be achieved. First, coming to diazepam. Now, this diazepam, you will learn about in detail about this drug in your central nervous system. So, this you just remember this much, that this drug acts through the GABA receptors. Okay, GABA receptors, you know, it is a inhibitory GABA is an inhibitory neurotransmitter in the central nervous system. So, it potentiates the effect of GABA. Okay, so it can cause drowsiness, dizziness, sedation, and all the CNS depressant effect and mental confusion. So withdrawal in the presence of dependence, when there is the adverse effect which you normally see with this drug is withdrawal effects. If the patient is dependent to the drug, then he might get withdrawal symptoms. Okay, so you can't keep giving diazepam all the time, because the high tendency of the patient to have dependence for this drug. Okay, so this drug is more actually used in epilepsy and as a sedative hypnotic rather than as a spasmolytic, but can be used also. Next is is there somebody talking? So next is baclofen. Baclofen also is an agonist as a GABA receptors. What does it do is it interferes with the release of the excitatory neurotransmitter. You know, GABA is a inhibitory neurotransmitter, right? So there is increase in GABA, and also it interferes with the release of the excitatory neurotransmitters. You don't want when there's excitatory neurotransmitter, there will be increase in muscle contraction, right? So the primary site of action of this drug is the spinal cord, but you remember one thing, this drug is very effective, and one important advantage of this drug is sedation is less than that what you see with diazepam. So that's one advantage. The patient can have somnolence and respiratory depression. That is, somnolence is he will feel the urge to sleep. Okay, so respiratory depression can be one of the adverse effects. Okay, so next coming to tizanidine. Now tizanidine is a now clonidine you have, I don't know if you have learnt about it, but no, I don't think you have. Have you learnt about clonidine alpha 2 agonist? Clonidine, I don't know whether you've learnt about it. Now it is a congener of clonidine. Okay, it belongs to the same class of clone as clonidine. Its mechanism is it is an agonist at it is an alpha 2 receptor agonist. What happens is it stimulates the alpha 2 receptors. So basically what any receptor, when it is stimulated, there is increase in the release of neurotransmitter. Now alpha 2 receptor is actually a autoreceptors. Or have you heard of autoreceptors? Hello, can you all hear me? Hello.
Yes, doctor, we can hear you.
Yeah. Okay, so what so alpha 2 receptors are actually autoreceptors. So autoreceptors are receptors where when you stimulate these receptors, there is no increase in the neurotransmitter release. Normally when you stimulate a receptor, there is increase in neurotransmitter release. There in autoreceptors, when you stimulate, there is decrease in the release of neurotransmitter. When you block it, there is increase. It the opposite is what happens. So this alpha 2 receptor is an autoreceptors. It has tizanidine is an agonist. So what happens is when you are stimulating the alpha 2 receptors, because it is an autoreceptors, there is decrease in the release of acetylcholine. So because of the acetylcholine release is decreased, then there because of that there is a relaxation of the muscle. So the patient can have drowsiness, hypotension, dry mouth, and asthenia. These are the adverse effects you can see with these patients. Okay, now coming to the next drug. Now if you see, do you remember, do you know these two famous personalities? What do you see? What do you see the difference between the left, this picture, and this picture? What is happening here? What are you seeing here? Do you see any difference? Who are these, by the way? Who are these?
Is that Brad Pitt?
Brad Pitt, okay. The other one?
Jennifer Lopez.
Okay. So now the thing is, these two individuals, now you see this left hand picture and the right hand picture of both of them. What difference do you see? Do you see a difference? Do you see a difference? Okay.
They have less wrinkles.
Yes, doctor.
Yes, they have less wrinkles. They look so clean and neat, the face. Okay, you see they have less wrinkles. They have, I'm sure all of you have heard about this Botox. This is what is commonly used by celebrities, and of course not only celebrities, they are some commoners also who like to use this Botox, which is very common nowadays. Everybody uses Botox, so who wants to look very young. So botulism toxin, how do they act? They prevent the release of acetylcholine from the cholinergic vesicles. You saw the nerve terminal there, the diagram in the first few slides, right? They decrease the release of acetylcholine from the cholinergic vesicle. So when the acetylcholine is released, there is muscle relaxation. So what happens? Use local injection for treatment of spastic disorders. When there is local spasticity, you can give injections on that side. For cosmetic, like for example, you want, see these people, they have like all the wrinkles are gone, you just they inject on the particular muscle where they want a relaxation. You need a beautiful smile, blepharospasm when there is spasm of the eyelids in case of urinary incontinence, hyperhidrosis when there is increase in sweating, ciliaria where there is increase in salivation. In all these cases, you can give botulism toxin. They can be very useful because they decrease the acetylcholine release. Okay. So next, coming to the directly acting, one example you need to know is dantrolene. I told you about malignant hypothermia, right? Where there is increase in the calcium from the sarcoplasmic reticulum. This actually is a wonder drug for malignant hypothermia. What this drug exactly does is it interferes with the release of calcium from the sarcoplasmic reticulum via the rhyodinin receptor channel. Okay, so if in malignant hypothermia, if there is mutation in the rhyodinin receptor channel, there is increase in calcium release. Okay, and because of that, muscle contraction. Now this dantrolene interferes with this release, and so it is very, very useful in malignant. In fact, it is a drug of choice. So when it is interference of release of calcium, there is excitation, contraction, coupling. For any muscle contraction, excitation, contraction, coupling is required. Again, physiology, you should know this. And this is prevented, so muscle contraction is prevented. Now, cardiac smooth muscle effect is very less. Only skeletal muscle, it's very slightly. They can cause muscle weakness, sedation, occasional hepatitis can be seen. It is remember, it's a drug of choice for malignant hypothermia. Okay, it's a drug of choice. And there are two important drugs which you need to know which causes malignant hypothermia. Succinylcholine, which we just spoke about. Halothane, this is a general anesthetic you will learn about in your central nervous system, I think semester 4, where you will learn about halothane. Now, the drug of choice for this is dantrolene. Dantrolene is a drug of choice. And what are the uses of central acting? Now, acute muscle spasm, any muscle spasm, torticollis. Torticollis is a situation where your the neck of the patient shifts to one side because of any muscle spasm. Then backache, when they have backache or neuralgia, ECT is electroconvulsive therapy, which I just spoke about. And tetanus is a situation where there's muscle spasm. And any spastic neurological condition like spinal injury, cerebral palsy, multiple sclerosis, stroke, where there is spasm of the muscle, you just want to relax the muscle, which is in that case you can give this centrally acting muscle. So to summarize, how do you differentiate? What is the difference between peripherally acting and centrally acting? Peripherally will block the NM transmission. Centrally will block the polysynaptic reflex in the central nervous system. Peripherally, the muscle tone is decreased. Centrally, also the muscle tone is decreased. Here, voluntary muscle is lost in case of peripheral, but centrally, you can have voluntary muscle because only one muscle part of the muscle is relaxed. You still can have voluntary muscle. No effect on the CNS peripherally because it is peripherally acting. Centrally acting has here only intravenous, here oral and intravenous. So peripherally acting you can use for surgical procedure. Centrally acting in chronic condition like muscle spasm and sprain you can use. So for a quick knowledge check, centrally acting muscle relaxant acting on GABA A receptor. Can you name which is it?
Diazepam.
Diazepam, very good. Centrally acting muscle relaxing acting on alpha 2 receptors. Acting on alpha 2 receptors. It acts on autoreceptors. Any idea?
Tizanidine.
Tizanidine, very good. Muscle relaxant that can be used in malignant hypothermia.
Succinylcholine.
It can be used in malignant. Succinylcholine causes malignant hypothermia. Can be used in malignant hypothermia.
Dantrolene.
Dantrolene, very good. Muscle relaxant which can cause apnea in patient with genetic predisposition.
Succinylcholine.
Yes, good. Succinyl. Muscle relaxant which blocks the NM receptor. Which blocks the NM receptor. One is agonistic at the NM receptor, one blocks the receptor. Which is the one which blocks the receptor?
D-tuberculin.
D-tuberculin, good. Drug used to reverse the effect of non-depolarizing blockers. Which is the one which reverses the block?
Is it neostigmine?
Yes, very good. It's neostigmine. Okay, thank you. done with the lecture. So any question, you're free to ask, please. No question.
Sorry, doctor.
Yes, Martha, tell me.
Can you explain on slide 34 regarding the power part?
Slide
Voluntary 34. Yeah, the voluntary
okay,
muscle
voluntary
movement.
muscle movement, even your peripherally acting, all the muscles are relaxed. All the muscles, okay? In centrally acting, you don't have total muscle relaxation. Apart, like for example, if you have a muscle spasm, this is actually only a part of that muscle is relaxed. You don't have a total muscle relaxation. So voluntary, you can voluntarily move the muscles in case if you take a, like for example, if you have a take a central muscle relaxant for maybe a sports injury, you can still move around, right? You can still move around, but that is your voluntary action will not be this thing. Your power of the muscle will not change. But if you give a centrally muscle peripherally acting, your total body muscles are relaxed. Total relaxation. You can't move your body at all. Did you get it?
I see. So, like, why is the centrally acting one preserved? Like, is it because it affects
Because
just
it's
some of the...
yeah, it is centrally acting, and because of its mechanism of action. There is a difference in the mechanism, right? This acts on the NM junction. So total muscle relaxation, all the muscles in the body. Got it?
Okay, understood.
Yeah.
Yeah, thank you, doctor.
Thank you, yeah. Any other question?
Doctor, I'm still a bit confused about the succinylcholine function. So, how does it end up with muscle paralysis from
Muscle
fasciculation?
relaxation, is it?
Yeah.
Yeah. So now, as I told you, you have to know your physiology well for this. What you do is, I will explain to you, but still, if you don't understand what happens, you go and check, go read your physiology about all this action potential and all that, depolarization, repolarization, you'll understand better. But still, I'll explain to you again, okay? So what happens is when you give succinylcholine to a patient, it will stimulate the nicotinic receptor at the neuromuscular junction. Okay, so when it stimulates the nicotinic receptors, the sodium channels open and causes depolarization. Okay, so when this depolarization occurs, there is excitation of the muscles, and because of the excitation of the muscles, there is fasciculation. Fasciculation means like small contraction, relaxation, concentration, relaxation. Okay, now what happens is the succinylcholine, it is not metabolized by any enzyme. So what happens is it persistently keeps stimulating the nicotinic receptors at the neuromuscular junction. Now, when it keeps stimulating, there is more depolarization occurring. So, when there is persistent depolarization acting, because depolarization, succinylcholine is persistently depolarizing so much that the repolarization does not occur. Okay, when the repolarization, see, for a new action potential to form and contraction to occur, you should have depolarization, then repolarization, and then goes to a new action potential. So repolarization does not occur. If you see this picture here, there is persistent depolarization without any repolarization. And because of this, because of persistent depolarization, there is fasciculation of the muscle, and ultimately it leads to paralysis of the muscle. Okay, and did you get it?
No.
Is this because the acetylcholine esterase cannot break down the...
Yes, correct. Because acetylcholinesterase cannot break down the succinylcholine, and succinylcholine is stimulating the receptor, going on stimulating, and there is persistent depolarization. Did you get it, Alicia?
Wait, so for the fasciculation, there is still repolarization, right?
No, see, first, because of twitching, excitation of the muscle, you will have fasciculation.
Yeah.
Okay, that then you have this depolarization. But it does not need a repolarization for this one. Got it? For a next action potential, you need depolarization. If you see here, now what happens is, see here, there is fasciculation which is occurring because of excitation of the motor plate. Got it?
Yes, so the muscle is contracting.
Yes, the muscle is, but it is not like slowly. It's like you're you're pricking it, like So that's this fasciculation, slow like twitching kind of a this way. That's why they get soreness. They get fasciculation, and then last is muscle relaxation because of continuous stimulation. Okay, are you clear, Alicia? Hello.
So in the end, because it keeps stimulating, that in the end there's no repolarization, so fasciculation will happen.
And then it goes to paralysis.
Okay, so fasciculation is when there is no repolarization.
Yes, correct. When there's depolarization happening, first fasciculation happens, and then happens paralysis. It's a process. First fasciculation, then goes to paralysis.
Okay.
Okay?
Yeah.
Clear?
Doctor, so if you want to reverse this effect, we need to administer plasma choline
Now this succinylcholine, see, this is gets hydrolyzed by plasma pseudocholinesterase, right? It gets broken down, so you don't have to do anything. After some time, it gets broken down. You see, it's very fast acting. Its effect goes off quickly. So you can give it only for short procedures, because like endotracheal intubation, you give it within few seconds, the effect is over. Now, you have to give plasma pseudocholinesterase only in individual where the plasma pseudocholinesterase is not present, like genetical abnormality, right? In such cases, pseudocholinesterase is not present in the plasma to break it down. So you have to give external plasma which contains pseudocholinesterase, so succinylcholine gets broken down. So for the reversing this, you don't have to give anything, because the pseudocholinesterase itself will hydrolyze it and decrease its effect. Got it, Joseph?
So we only need to administer it if the patient is deficient in this plasma cholinesterase, and usually we don't need to do anything.
Yes. Only if there's a defect. If there's plasma pseudocholinesterase is not effective or not acting because of this genetic predisposition.
Okay, I understand now, doctor.
Yeah.
Thank you.
Okay. Any other question? Okay then. No question. Thank you so much. Have a nice day. Take care.